Fibroids are indeed the most common benign tumors of the uterus. Almost 40% of women, when you do a scan, will show fibroids, which might be asymptomatic or symptomatic. The most common myth, which even healthcare providers and the patients have, is they disappear after menopause. That is absolutely wrong. Need not disappear after menopause. What happens after menopause is, what we need to understand is that fibroids are hormone dependent. So with menopause, when the hormones come down, the size can come down. So sometimes definitely the symptoms will disappear, but not necessarily. So we have to, each case is different and we have to watch each case separately. These fibroids can increase in size or can start bleeding later because of the increased estrogen, and can also cause a lot of pressure symptoms and the bladder and the bowel. So the thing that fibroids never become malignant, fibroids will not cause any problem after menopause, are the two myths which both the healthcare providers and the patients have. See, fibroids is something, depending on the size, number, location, we need to take a call, and depending on the need of the patient, we take a call. So I think things happen, and I believe a lot in the destiny. It is just destined that the patient had to be operated by me. So this patient was in the north part of some Karnataka, where she was examined for the gynecologist there. She was an unmarried girl with almost the fibroids, multiple fibroids, causing breathlessness. She was not able to lie down straight because of so many fibroids in the abdomen. So the doctor who saw there said, you are either for hysterectomy, or only person who can remove only fibroids would be Dr. Manjula from Hyderabad. So she came down all the way from Karnataka to us. Then we had optimized her, took care of her respiratory problem. Anesthetist has taken care, and we did a small mini lap operation through which we have removed 84 fibroids. The complications which we can usually face during such fibroids would be bleeding. So many fibroids, the uterus itself will have a lot of blood inside it, and fibroids are very vascular. So blood is something which is something we need to be careful. Second complication which can happen is they go into DIC. When so much of bleeding happens, there is consumption, where there will be a lot of bleeding, which continuously bleed without clotting. So with these things in mind, we had optimized her by giving blood transfusion, see that her anemia is corrected, and 2 units reserved, and then we go ahead. Third would be during surgery, if the torrential bleeding, she can end up with hysterectomy, but luckily for me, till now, we never had to do hysterectomy for a myomectomy. So there are the techniques which we do during surgery, like to decrease the, minimize the amount of bleeding which we have, like uterine artery ligation, like giving vasopressin into the uterus so that they bleed less, then immediately suturing the myoma bed so that they don't bleed. So all these things, luckily I have a fantastic team who has assisted me very well, and we could do this. I truly believe that the treatment should be depending on the problem of the patient, rather than treating the patient to the solution which we have. So when a patient comes to us with a problem, we should think out of the box to give the best solution, rather than what we already have and try to fit it into the problem. That's how all these innovations come. Innovation does not mean we need to create something new. We need to just take something which is already existing in 2 different fields, get them together, come up with a new solution, also is innovation. So the neovagina technique of Anagani started like that, giving out the solution to the patient in such a way that there is no incision, the surgical time is hardly 10 minutes, and the outcome is such a way that sexual life is normal, and nobody can actually say that she has undergone a surgery for the neovagina. The similar way in fibroids, when we came up with the mini lab technology, if it's going to be more than 50-60 fibroids, where from an incision which is 4-5 centimeter, we can take out every small fibroid which is there, rather than ending up leaving some 1 or 2 fibroids. Second would be, there is a crowbar technique which we have come up in myoma technique in minimally access surgery, where we use a myoma dissector. It's a customized instrument which we have developed, which has a spoon-like instrument which serrations and the last. So we use it like a crowbar, so that just like in a village, how a farmer or anybody lifts any boulder, like using a crowbar, we remove all these boulders called fibroids using this crowbar technique. So I feel that is the reason behind our success in the myomectomy techniques, where we come up with hardly any blood transfusions, no blood loss, and the outcomes where we do a surgery today, it might be 28-30 fibroids, next day the patient is out, and within 6 weeks they can have a normal sexual life, and every exercise they can do, and after 3 months they can think of pregnancy. So when we think for the best outcome for the patient, we can come up with whatever we call as innovations. So innovations is the way to go forward to give the best to the patient. Fibroids definitely affect the quality of life, but everything need not be symptomatic. So we take a decision depending on whether the woman is asymptomatic or symptomatic. When we talk of symptoms, what are the symptoms? Just the presence of a mass can be a symptom. She might be having a feeling that there's a mass there. It can have a pressure symptoms like putting a pressure on the bladder that she'll have to go for frequently to the urine, or obstruction of motion or something like that. But the presence of it can also cause infertility when it is present inside the cavity, or it can be just the presence of it inside the muscle can cause the implantation from not happening. And it can also cause increased bleeding PV, and if they go to anemia, they can also have a lot of pain during menstrual cycle. The pain itself can cause dyspareunia, having problem during intercourse. The frequency of intercourse comes down, and again infertility. But still, why do women get postpone their problems and are scared of going to the doctor? First, the fear of surgery. They're always worried that surgery is a major thing and it can cause more problems. Second, the hope that some medicines would be there which will take it away. Now, the medicines which have been tried, yes, people have tried different medicines to decrease the size of fibroids, but fibroids do not disappear. Yeah, it can decrease in size by stopping the vessel vascularity to it, but those medicines, certain medicines which have been tried, have caused liver damage, and they have been completely banned in many countries. So medically it doesn't work. Then there are some minimally invasive techniques which people have tried, that is uterine artery embolization. Now, they should not be given when people are thinking of fertility, because when we are embolizing, it can be super specific, or it can cause the uterus also to get embolized, uterine artery also to get embolized, means stopping the blood flow. That can affect the fertility. Now, when we stop the uterine artery or even fibroid embolization, the size can come down, it can cause intense pain, and some of it can shed through the uterus. So all these things are an issue. So when I definitely feel, but nowadays more and more techniques are coming, which is like microwave ablation or HIFU ablation of the fibroid. These are all for people who can actually think of only bleeding as an issue. But when fertility is the thing, I believe that you have a fibroid, if that is the cause of the infertility, that should be removed. The outcomes of pregnancy is very, very high, as high as 80%. So if done properly, a good surgery will not leave any mark. They can also have a vaginal delivery if the endometrial cavity is not involved. So proactively, women with infertility, when they have to be examined and checked with the ultrasound, if the fibroids are there, if there are multiple, and if the other causes for infertility are ruled out, they should be thinking of myomectomy before you go ahead for other treatments like IUI or IVF. See, regenerative medicine is here to stay, and it is very close to my heart, because when we look at regenerative medicine, whether it is stem cell or PRP, we are looking at growth factors. So we are looking at neoangiogenesis to give new blood, new circulation, new thing to the tissue for regeneration and rejuvenation. So we are looking at regeneration, rejuvenation and replacement. So we look at giving lot of blood supply to it. We look at anti-inflammation to decrease the inflammation going on, and we look at apoptosis so that inflammatory cells go away and the new comes. So we look at ovarian rejuvenation and endometrial regeneration. We also treat it for PCOS. We also give it for endometriosis. For fibroids, as of now, we are looking at something which can decrease it. We have to decrease something which can kill the fibroid from growing. So yeah, from not coming back again, we can still try it. But whatever is already there, that is something which has to be removed. So the same way when I talk to the patients about endometriosis, whatever my eye can see, I will remove it. Whatever my eye cannot see, to prevent it from coming, we can give this regenerative medicine into it. Yes, we can look at regenerative medicine for fibroids, but it is going to take some more time. Removing unnecessarily the uterus when it is not necessary. This was something which was happening 2-3 decades ago, when they thought the purpose of the uterus was only to deliver. Once the children are born, it can be removed. It's like a waste organ. Then over time, because of the advocacy of a lot of doctors and everybody, then people understood that there is a blood supply which comes from the uterus, which goes to the ovary, and removing uterus at a younger age will lead to premature menopause. So now, luckily for us, many people do think of second time when and somebody suggests the uterus. But saying that, it has to be the balance. Fibroids, we don't have to remove the uterus unless they're perimenopausal during the age of menopause, 45 plus, or multiple fibroids that no uterus can be saved. But rest of the case, it has to be either uterine artery embolization if they're looking at one or two and they do not want surgery, or you can look at only myomectomies, or we can look at only bleeding is a problem, then TCRE where the lining can be removed. Or if it's a small size, only bleeding is the issue, we can look at Mirena, which is an intrauterine device which can decrease the amount of flow for about 40 to 60% or sometimes complete amenorrhea. So there are alternative techniques. It is our duty as a healthcare professional to give the option to the patient, and it is patient's choice. So they have to be given. Anybody less than 40 years, definitely it has to be myomectomy where only the fibroids have to be removed, or you can look at other alternatives like Mirena, TCRE, or even uterine artery embolization or MRFUS. Anybody more than 45, if the patient is okay, we can look at hysterectomy. But between that age, depending on the need, number, symptoms, and if it's growing faster, it is a recurrent case, we take a call depending on the need. So hysterectomy is never a choice for myomectomy. Myomectomy, either abdominal, laparoscopic, hysteroscopic, depending on the location of the fibroid, is the treatment for myoma or fibroid uterus. Yeah, many people do come, including the general surgeons, because they have to be trained properly when they do surgeries like that. So first point we always tell them is optimize the patient. With hysterectomies, even with 8 grams hemoglobin, we do go, but for myomectomy, we want at least 10 grams hemoglobin. That's the first point. Second, understand that when we are doing myomectomy for infertility, we should look at the fallopian tubes and where the others are and see that we do not do damage to the fallopian tubes and ovaries which are there. Third, we be away from the uterines, which is a major circulation for this. Fourth, fibroids are always intracapsular. There is something which is protective given by God called capsule. So we give the vasopressin to decrease the amount of bleeding which can happen during surgery, and the incision should be given in an oblique or a transverse way, avoiding the fallopian tubes and the ovaries, and in such a way that it cuts the capsule. So incision should not be too small, it should not be too big so that suturing becomes messy. So we give just enough that the fibroid juts out of it, and then by using crowbar technique, you contraction and traction using myoma screw and the crowbar technique, we remove the fibroids. Then the suturing technique, we use the barbed sutures. So we train them to use the barbed sutures. So the pressure inside when we are suturing should be tight enough to cause hemostasis, not loose to cause a lot of hematoma. So these are things, integrities which we say, and at the end of the procedure, we tell them if the adhesions are not required, adhesion prevention technique like intercede or Surgisil to decrease the amount of bleeding. So if taught properly, and we always look at removing at least 90 to 95% of fibroids which are there, if not, albeit if not 100, because we cannot remove a small 1 centimeter seedling fibroids. If we do seedling fibroids outside, we do a myolysis of it. So if taught properly, if people understand the technique properly, and if necessary doing a uterine artery ligation, outcomes are going to be good. There need not be any fear of myoma and myomectomy. See, the whole concept of robotic comes from the thing that the whole 7 degrees of flexibility, where a hand can move to 180 degrees, whereas the robotic arm can go to complete 360 degrees. So it can suture the way it is. With myoma, the steps would be when we give some AVAS to decrease the vascularity, some injection, then we cut open, and then we take out the fibroid out, and then we have to suture the myoma bed in such a way that there won't be any dead space, not the suture which we have done will not become weak, and after that we take out the specimen. So with the robotic, the precision helps us to correctly locate the fibroid in the exact place, and then give the vasopressin injection, then the incision in such a way that there is no bleeding, and hemostasis can be secured very well. And with the suturing technique, the best is the precision of energy, and the suturing techniques are the positive things of robotic. So we suture in myoma bed in such a way that they don't end up to be having any bleeding, nor any dead space inside that. So robotic definitely has an edge over the open or laparoscopic surgery when it comes to the suturing of the myoma. So going forward, except the removal of the tissue, which is done by doing a power modulation in bag, which is to be done laparoscopically, rest of would be done by robotic. So it is a robotic assisted or lap assisted robotic surgery when it comes to fibroids.